Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. Today, my guest and I will be diving into the brain, your most vital, complex, and vulnerable organ, and why protecting it matters more than ever, especially for women. Here's a fact that doesn't get enough attention. 2 out of 3 people with Alzheimer's are women. And this isn't just about old age. The seeds of cognitive decline can start as early as your 40s or even sooner. And so we are going to talk about why women are at greater risk for Alzheimer's and dementia, the brain hormone connection during menopause and midlife, what you can do now to preserve your memory, focus, and cognitive resilience, how genes like the ApoE4 interact with lifestyle and cholesterol, and how belly fat or visceral fat affect cognition and brain health, and the power of early personalized prevention. My guest today is Dr. Kellyann Niotis, the first fellowship-trained preventive neurologist in the world, specializing in risk reduction strategies for neurodegenerative disorders such as Alzheimer's disease, Lewy Body Dementia, and Parkinson's disease. Dr. Niotis led the preventive neurology program with Dr. Peter Attia's medical practice called Early Medical and managed the country's first Alzheimer's prevention clinic at the Weill Cornell Medical College, where she developed research programs for Parkinson's and Lewy body dementia prevention. Her work has been published in several media and medical journals, including Neurology, Nature, Mental Health, Frontiers of Aging, Neuroscience, Aging and Disease, Movement Disorders, Journal of Alzheimer's Disease, Alzheimer's Dementia, and Journal of the Prevention of Alzheimer's Disease, and has been presented at national and international conferences. She is passionate about the budding medical space of preventive neurology, in particular pertaining to the advocacy of preventive neurology policy changes and making treatment and education more accessible to the masses. She has received numerous honors and awards, and her opinions have been featured in popular media outlets, including CNN. So whether you are looking for tools to sharpen your brain today or thinking long-term about protecting yourself and your loved ones, this conversation is full of insight and hope. A little medical disclaimer before we dive in. By listening to this podcast, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. And this entire disclaimer applies to any of my guests on my podcast. So let's sit back, open your minds, and let's dive into the brain. Hi, Dr. Niotis. Welcome to the Health Trip Podcast.
Hi, Jill. Thank you so much for having me join today.
Yeah, I'm so excited to have you here. I mean, what is more important than our brain? And in menopause, and I am a postmenopausal woman, I can tell you that at least 5 to 10 times a day, I think that I have Alzheimer's and dementia because I am constantly forgetting things. My cognition is not the way it used to be. I have to have notes all over the house. And so I think, I'm not alone in that. There's a lot of women in midlife really struggling with their brains right now.
You are absolutely not alone. And that's exactly what I was going to say. One of the most common complaints and things that I see women for are these concerning cognitive changes that happen in midlife. And especially in women who know that they have risks due to their family history, or they know they have a specific genetic risk factor, it can be really concerning and cause a lot of stress and worry. So I'm looking forward to diving deeper into that, and hopefully we can shed some light on when to worry and when not to worry.
Yeah, that sounds fantastic. So what even inspired you to become you are the only preventive neurologist, is that correct?
Well, I'll say that there are a handful, one specifically that trained me, Richard Isaacson, a dear mentor of mine. But he helped create a preventive neurology fellowship training program at Weill Cornell, and I was the first fellow, and unfortunately that is not in existence, but I hope to change that and rejoining the faculty at Cornell to hopefully build that fellowship program back up and have a new generation of preventive neurologists coming.
Yeah, because you're just not enough to help everybody out there.
I agree. I
Yeah.
agree. Too
But
much
what,
work for one.
100%. But what inspired you to even go down that path of preventive neurology? Is it something that has to do with a personal story, a family history?
Well, I have to say that, the neurology and the brain really has always drawn or inspired me. There's so much mystery, so much potential. Our brain is who we are, it defines us. And what really inspired me to pursue preventive neurology was this realization taking care of patients in medical school in neurology with really advanced Parkinson's, advanced Alzheimer's, and realizing we're intervening way too late. I was a fourth year medical student. I won't ever forget this lecture by a orthopedic doctor that had turned preventive medicine, and
Hmm.
he gave up surgery and started to work with his patients on reversing or correcting their heart disease with lifestyle and um, earlier medication interventions. And I just thought, like, why does that have to stop at cardiology? Can't we intervene earlier in diseases that affect the brain, which pretty much affect our entire being? And unfortunately, by the time symptoms appear, a lot of irreversible damage has occurred. So I really just wanted to be a part of this shift from reacting to the disease, prescribing medications that help treat symptoms to really help people protect their brain over time.
Yeah, one term that I learned fairly recently from a mutual acquaintance of ours is primordial prevention, the step before prevention. And it sounds like you are in that world as well when it comes to the brain. Do you want to share what primordial might mean in terms of brain health?
Yeah. So, and we'll talk a little bit more about this later, but there's a shifting mindset of understanding what risk for neurodegenerative disease means. And for those listening who don't recognize this, what's so interesting and what's so special about diseases like heart disease and Alzheimer's disease is that they develop over decades. These pathological changes that are contributing to a heart attack, for example, are starting 10, 20 years before an actual heart attack happens. The same is true with Alzheimer's disease. There are pathological changes that are happening in the body and in the brain decades before. When those pathological changes happen, we use a term, depending on what disease process we're talking about, called preclinical disease. But even before that, we can identify that there are people at risk. And that may mean they have a family history, they carry a gene called ApoE4. And just because they don't have the early pathological changes happening, or to use the analogy that's similar to heart disease, evidence of plaque being built up, it doesn't mean that that won't happen to them and that they're still
Mhm.
not at risk. So I really love working with patients who are in this very, very early stage where we
Yeah.
have so much opportunity to intervene.
Yeah, I love that. So let's start from the beginning of the neurodegenerative disease story. Like, what is the best way? Because it's kind of confusing. If we're not you, it's confusing. Alzheimer's, dementia, there's Lewy body disease, Parkinson's. What's the overarching umbrella? And then how can we best think about all of these different nuances?
So, neurodegenerative disease is probably the overarching umbrella term that I would use. That is a mouthful. What the heck is neurodegenerative disease? So, neurodegenerative means neuro referring to the brain or brain cells or nervous system, and degeneration is breakdown or death. So, it's really dying off of nervous tissue. In the case of in my particular niche of neurodegenerative diseases, I'm particularly focused on diseases that relate to the degeneration. See, I can't even say it sometimes. The
Right.
degeneration of brain cells.
Mm.
So those are diseases like Alzheimer's, diseases like Parkinson's, Lewy body dementia. Other more uncommon diseases fall into this category, like frontotemporal dementia. And we use this very big umbrella term of dementia. And what does that mean? Well, there are neurodegenerative forms of dementia, such as Alzheimer's and Lewy body and frontotemporal dementia. But then there are other not neurodegenerative forms of dementia that could even be reversible. For example, depression can cause a pseudo dementia. Vitamin B12 deficiency can cause dementia. So dementia does not necessarily mean that there's death of the brain tissue. It just means that cognitive function is impaired to a degree that is interfering with someone's activities of daily living.
Okay. Why are women, especially in midlife, like myself, at greater risk for Alzheimer's and dementia versus men?
That is $1 million question. So we don't fully know the answer to that. We do understand that there are biological sex related differences between men and women in terms of their risk for developing different types of neurodegenerative diseases. So, for example, men seem to be more predisposed to developing Parkinson's disease, whereas women seem more predisposed to Alzheimer's disease. And a
Hmm.
lot of the buzz around why that's the case is it really ties down and relates to hormonal changes. And we'll get there, but that's probably not the whole picture. There is a really complex interaction between biological sex, genetic risk factors like ApoE4, for example, that predispose a women or women's brains to having a predilection, to having risk for Alzheimer's disease. For example, there is a gene that actually localizes to the X chromosome, which is the female specific chromosome, a ubiquitin gene that actually predisposes women to laying down more tau pathology, which is a pathological finding in Alzheimer's disease. And we understand that women who carry this high risk gene called ApoE4 seem to be more harmed by this gene than men. So there are certain biological sex related differences that we don't fully understand. But as time has moved on and as science has grown in this field, we are understanding that that hormonal changes that happen in midlife do seem to impact the female brain. And whether that's directly due to these steep declines in female sex hormones that put women's brains at higher risk, or related to indirect effects of those hormonal changes, such as once your hormones start shifting, you end up having higher cholesterol, which is a risk factor for Alzheimer's disease. Your body composition starts changing, which is a risk factor for Alzheimer's disease. Your sleep is impaired. So there are so many direct and indirect hormonal changes that happen to women specifically that seem to really put them at a higher risk, but hormones probably aren't the whole story.
Yeah, but while we're on the hormone story, there's something called the timing hypothesis. And I'm sure, of course, you know what that is, but to some of the listeners who might know, it's whether or not using menopause hormone therapy is safe for women after age 60, I believe, or within 10, outside of that 10 years of menopause. And so there's, a huge population of women who missed the boat on having that conversation to find out whether or not they're even a candidate for menopause hormone therapy. And they're all wondering what can they do for their brain health. So can you speak to the brain changes that are going on, the timing hypothesis, and is menopause hormone therapy, I know it's not FDA approved for the use of reducing the risk of Alzheimer's and dementia, but do you see that coming down the road?
Yeah. Okay. So many good
I
questions to
know.
dive in.
Yeah. And
Um,
I'm not going to remember them, so hopefully you wrote them down.
example. This is a test of my
Right.
skills here.
Yeah.
This is like
Yeah.
going to the dentist and making sure they have good teeth.
Uh-huh.
Um, so let's go to the first question. Full stop. We do not have enough research out there, high quality research out there to have a perfect answer to this. But let's break down what the current studies show. So it seems like there's this critical window of opportunity for women, and that is really in the perimenopausal window. And within, as you said, somewhere between 7 to 10 years post menopause. Um, Studies have shown that after that, hormones may not do anything. They may increase risk for dementia, but I've also seen studies, even in women who are 80 to 85, that hormones could help their cognition. So I don't think we have a perfect answer for what happens outside that 7 to 10 post menopause period yet. I think we need a lot more studies in women at that age who are taking hormones for other reasons, for maybe bone health and so forth.
Mhm.
But we don't have a perfect answer for that. But why is this critical window in perimenopause and several years after? It really does relate, as we alluded to a little earlier, to these shifts in female sex hormones. So it's these rapid fluctuations, especially in estrogen, but probably also progesterone, although a lot less research has been dedicated to studying progesterone and its long-term effects in female brain health, that seem to put women more at risk. So women's brains actually express estrogen receptors, and there's lovely studies done by Dr. Lisa Mosconi at
Mhm.
Weill Cornell, really showing how the female brain has estrogen receptors and they start to upregulate during perimenopause and after menopause because they're trying to soak up as much estrogen from our periphery as possible because it's so crucial for neuroplasticity, which is maintaining the ability of the brain to change over time. So lots of cool, interesting work is being done. And to your question, like, is HRT recommended? Is it ever going to be FDA approved for this indication? I don't know if that will happen in the near future because the studies that it will take just require such a long study duration and they can be extremely expensive. Of course, we want those studies. And on a smaller scale, some of the research that I'm doing through the Institute for Neurodegenerative Disease is really looking at this question. We're doing it in
Mhm.
a much smaller setting and a much smaller scale, but looking at women who are either in their 40s and 50s in this ideal critical window, and then also experimenting with women who may have different reasons to be put on HRT, such as they have pretty significant osteopenia or osteoporosis. We know estrogen is bone
Mhm.
protective. If they have other indications and are willing to take a potential risk of trying it, we're really looking at changes in blood-based biomarkers that mean changes to things like amyloid in the blood, changes to tau proteins in the blood in women who start these hormones. Um, I don't have a ton of preliminary evidence to share with everyone yet, but some very, very early suggestion supports this critical window theory, which is that hormones at that ideal time, especially in women with high risk genes like ApoE4, do seem to positively impact these biomarkers.
Oh, well, that's wonderful. And it's so amazing that you're doing this research, even if it's on a smaller level, at least starting to explore, because there are so many women out there who are suffering. And there are still many women out there in perimenopause who are working with physicians who aren't aware that they're able to start menopause hormone therapy in this window prior to menopause. A lot of the clients that I work with say their doctors want them to wait until they're in menopause. And so I do a lot of education. At the end of the day, that's between the conversation between them and their physician. But education is so key in this, especially for the pre-menopausal women. I just did a podcast and devoted it to pre-menopause and how to start thinking about your toolkit now before you hit perimenopause so that you are empowered and can be a better advocate for yourself.
Yeah, it's so important. We don't really think about the fact that or
Mhm.
perimenopause can start for some women in their 30s.
Yeah.
And being aware of potential side effects or symptoms of hormonal shifts can be really, really critical. And I'm a firm believer that getting your hormones in check really will benefit your whole health. As we spoke about earlier on in this episode, the indirect effects of fixing your hormones on these modifiable risk factors for Alzheimer's disease, like improving your sleep, like improving your body composition and your cholesterol, your blood pressure, all those
Right.
things that hormones affect are so important to our brains.
Yeah, we're going to dive deep into some of those modifiable risk factors as well. But while we're still on to the woman who's really struggling with her brain health, what is the difference between mild cognitive impairment and brain fog and neurodegeneration or Alzheimer's and dementia? Women are walking around and they are thinking they have dementia when it might be just brain fog. But how do we know the difference?
Okay, so I think it's probably easiest to start at dementia. So, dementia means that you have a significant cognitive impairment that is interfering with your activities of daily living, meaning you can't do your finances anymore. You need help with that. You may not be able to drive to work. You probably aren't working. You're making mistakes on your accounting. You may not be able to do self care like bathe. So, dementia is a pretty clear change in your cognition. Mild cognitive impairment can be a little more subtle because it doesn't interfere necessarily with your ability to function, but the symptoms are obvious enough that other people in your life often start to notice,
Hmm.
especially people that you work very closely with. And that's really a giveaway. If your family is starting to say, like, I told you that already. We just had that conversation, or you already told me that story, or coworkers are starting to wonder why you're missing a lot of emails or making errors in the way that you're wording sentences. Those can be signs of mild cognitive impairment that can be a little bit more subtle. Um, Brain fog is really vague. And maybe we should talk about brain fog and just normal cognitive aging and
Yes,
cognitive
please.
changes that happen in midlife to women specifically who feel it more because of these hormonal changes, which, by the way, hormones definitely help that those acute cognitive changes that women will feel when they're going through midlife changes. But everyone's brain will age over time. That is normal. There are certain cognitive abilities that get better as we get older, actually. So some things do age like fine wine, such as our wisdom, our vocabulary, our intellect. Those things all get better because we get more experiences and we have more learning. But there are certain cognitive abilities that start to decline. Attention is one of these big ones that starts to decline. It becomes more difficult to multitask. It becomes more difficult to focus for prolonged periods of time. Our processing speed starts to decline. How quickly we can start taking in information that we're seeing and responding to it. Reaction time starts to decline. Working memory, our ability to manipulate information in real time, all starts to decline. So that can feed downstream into these cognitive domains that make people feel like they're losing their memory. Um, Meaning, if you can't pay attention or process what's in front of you, it's much more difficult to learn it. You may find yourself having to reread passages or write things down more frequently because these are ways to reinforce the learning process because your attention has started to decline.
Mhm.
Um, and that'll trickle down into feelings of I'm forgetting things because if you never learned it, you'll never remember it to in the first place. So people will complain, I'm losing my memory, I'm losing my memory. And then when you actually dive deeper, you do cognitive testing on them, you actually see that their attention is impaired. And that's really what's the culprit behind that perceived memory loss. And those are things that happen normally in aging, as we said, but they happen a lot more suddenly and abruptly during perimenopause. And it can make women feel like, I can't find my words. I'm like, my brain's just working slower. And that's often described as a brain fog for a lot of women. But brain fog is really, really vague. It can mean a lot of different things to a lot of different people. For example, this feeling of just generalized malaise and fatigue and heaviness, and versus like a true feeling of inattention, or I cannot pay attention right to whatever's in front of me. But if I'm working out or exercising, like I don't feel that necessarily a brain fog. So it can really mean different things to different people. And I always push back when people say that I feel brain fog. Like I want to understand specifically what they mean by that, because it's a little tricky.
Yeah, because you want to know, is this person actually having brain fog, or is there, some overlap with early signs of Alzheimer's?
Right.
Yeah. I mean, you just described my day every day, And, the other thing is in perimenopause, and women are going to their doctors and they aren't sure they're in perimenopause, and maybe they're not working with a menopause care expert, an OBGYN or primary care GP, and they aren't asking the right questions. And instead, they're saying, you have a lot of kids, you're really busy, you're, burning the candle at both ends. Of course, you're feeling overwhelmed and have, attention difficulties and focus difficulties. And for the woman who has ADHD, it's even more profound during the perimenopause transition into menopause. So there's a lot for us to really be educated on and know the signs. But I really like how you said where Alzheimer's and dementia, other people outside of your circle are noticing changes going on, and that's a really good warning sign right there.
Definitely. And there are other subtle warning signs that may be relevant that don't necessarily pertain to cognition. But what's always tricky about these other warning signs is that there are other reasons that you could be having these things, like mood changes, anxiety. Well, that also can happen during perimenopause. And this is what's so frustrating for a lot of women, and what does lead to a lot of concern in this period, especially for women who are educated and understands that this is the time my brain is most vulnerable. Well, is it happening to me right now? Like, how do I know? And that can be really difficult for any given person to sort through on their own. And you might need the help of a neurologist.
Yeah, very good information. Let's switch over to the ApoE4 gene. This is something that's really near and dear to my heart because I am an ApoE4 carrier, and you're going to explain what all of this means. And three of my kids are also. So we have a higher risk of, it doesn't mean we're going to get Alzheimer's, it just means we're at a higher risk of possibly getting Alzheimer's. So can you explain the role of ApoE4 gene in Alzheimer's risk and how it differs for maybe women in midlife?
Yeah, for sure. So the ApoE gene stands for apolipoprotein E, and this is the best studied and most significant genetic risk factor for Alzheimer's disease. A lot of people also don't realize that it's a risk factor for Lewy body dementia, which is related to Alzheimer's disease, but slightly different. Um, it is not a deterministic gene, meaning if you carry the high risk variant of this gene, which we'll talk about in a second, it doesn't necessarily mean that you will get Alzheimer's disease or Lewy body dementia. You are not doomed. Your genes are not your destiny in this way when it comes to this particular gene. What does this gene do? That is so important to understand because it helps break apart how this gene may contribute to neurodegenerative disease later in life. So the ApoE protein, which is what this gene is encoding, is a protein that's heavily involved in cholesterol transport throughout the body, but especially important to cholesterol transport in the brain. The brain is a very cholesterol rich organ. It needs cholesterol for important processes to maintain the health of our brain cell membranes, to synthesize neurotransmitters, which are involved in our thinking and our movement. Cholesterol often gets a bad reputation as like, we don't want it, but we do
Right.
want some of it. It's kind of Goldilocks. You want the right amount, not too much, not too little, and your brain needs it. It turns out that our brains are making all of their own cholesterol, which I'm sure we'll get into.
Mhm.
We modify our peripheral levels of cholesterol. We often aren't doing anything to what's happening specifically in the brain because it's making its own cholesterol. But back to ApoE. ApoE is the protein that's responsible for shuttling cholesterol and lipids to different parts of brain, to different brain cells, so that they can be used, so the cholesterol can be used in these important processes that I alluded to. So our brain needs to shift cholesterol from those cholesterol producing brain cells to the ones that don't produce as much cholesterol so they can utilize it. And ApoE is so critical for that. So ApoE, as I said, is a protein, and it comes in 3 different types, what we call in medicine or in science alleles. It comes in an ApoE2, an ApoE3, and an ApoE4 type or isoform. And when it comes to the gene, everyone gets 2 copies of this gene. We get one from our mom and one from our dad, and us scientists call this someone's genotype. So the wild type or most common genotype is ApoE33. This is the ApoE variant that is efficient at transporting cholesterol between different brain cells. ApoE2 is actually the protective variant. I don't love calling it that, but people who do have ApoE2 seem to have a lower risk of developing Alzheimer's and Lewy body, have improved cognitive outcomes or improved cognitive aging later in life. They can and still do get dementia and Alzheimer's, but if they do, it's typically at a later age. It's a super efficient transporter of cholesterol in the brain, and it's a super clearer of cholesterol peripherally. And then this higher risk variant is called ApoE4, and that is the least efficient transporter of cholesterol and the least efficient clearer of cholesterol. So what happens in people who have this gene, as ApoE4 variant of the gene, is that cholesterol doesn't get shuttled appropriately to the right type of brain cells, and cholesterol can start to accumulate in these brain cells. And when that happens, it's very toxic to the cell can die. This is one way ApoE4 contributes to neurodegeneration. There are other ways as well. It changes the way that we process omegas. It changes the way that we handle peripheral cholesterol. It changes the way our body can clear toxic proteins that lead to these diseases. So there are many mechanisms by which ApoE4 increases risk, but a huge one really relates to its ability to shuttle cholesterol in the brain.
And we know that during the menopause transition, women's cholesterol panels look different. Many women experience a spike in their LDL-C, their total cholesterol, maybe even their triglycerides. And so we know that it's really important to also be working not only with someone who is well versed in neurodegenerative disease like yourself, but also in assessing your risk for cardiovascular disease risk. Because this door is opening for women, should all women in midlife, if they don't know their ApoE status, should they all go get tested?
It's a fantastic question. So I am always cautious to give one size fits all recommendations and advice because I don't think that that exists in what I do. I don't think there's a right or wrong answer to that question. I'm personally in the field of, if you don't know what you're up against, you can't be
Yeah.
proactive. So, and because this gene isn't deterministic, and because we understand how this gene can contribute to disease and potentially levers that we can pull to get people off the path of neurodegeneration that have this gene, I'm a proponent of testing for the right person. There are some women and men who learn about what if they were to learn about this genetic predisposition, it would be all consuming to them. They would
Yeah.
think about it all the time. It would cause undue stress. And in that situation, I don't want you staying up all night thinking about
Right.
this, because that's
Right.
not helping your brain health. So, you know, there are also patients that I'll see that'll say, you know what, you're right. It's going to change the way that you treat me. I don't want to know what I have, but you can know and just make those decisions for me. And that works. It just depends on what someone's own understanding of their anxiety levels and feelings about knowing these things are. I don't think there's a right or wrong answer to that.
Hmm. Yeah, that's really interesting. I work with a lot of women who want advanced testing. They want to know. They've been to a lot of doctors, they've struggled with a lot of things, and they're kind of sort of at their wits' end. And they just said, I just want to know, the path for me, and I want to get on it now. I don't want to wait 15 years. But you're right. It is a very nuanced conversation and individual decision to find out different genetic status because you can find out genes on Parkinson's too as well, right?
Absolutely. Yes.
Yeah.
And again, a lot of those genes are not deterministic. They just
Right.
increase your risk a little bit. People always push on saying, well, I have one copy or I have two copies of ApoE4. What does that mean for me? How much of a risk does that put
Yeah.
me at? And those questions are really, really hard to answer on an individual level. We can look at the population-based data all we want, but that does not tell us what one's individual risk related to ApoE4 is. For example, if you have no family history of neurodegenerative disease and you have ApoE4 and people are living into their 80s, 90s to 100 and there's nothing there, like you've inherited some protective genetic factor along with that ApoE4, which has potentially silenced that gene completely. And one interesting thing that we're seeing in our research is we're testing ApoE expression in genes. And what we're finding is that the people who have ApoE4 can have varying degrees of expression of ApoE4. Even people with ApoE44 can have varying degrees of expression of ApoE4. So just because you have one copy, it doesn't mean that that is your sole determining factor. There's lots of other things that go along with ApoE4 that influence the way it's expressed and manifests in someone.
Yeah. I don't know if you saw on LinkedIn where Dr. Thomas Dayspring is very active there in an X. And he just recently posted this week a study that suggests we know that the science is saying you have to keep your LDLC, your LDL cholesterol lower for longer. And we know that lower for longer also is good. So whatever's good for your heart is also really good for your brain. So that might mean for someone that they have to take a statin or a lipid lowering medication. There's other things besides statins, but there's a lot of physicians, OBGYNs, and urologists on things like TikTok and Instagram who are constantly sending this message to midlife women not to take a statin, that doctors are giving away statins like candy. Don't take the statin because the statin is going to cause Alzheimer's disease. So, can you speak to that? And
Yeah,
yeah,
I would love to, because nothing bothers me more than spreading misinformation on the internet.
yeah,
And for whatever reason, there is tremendous amounts of misinformation on the internet about cholesterol and cholesterol management, and it's really based on nothing. What we know is that having high cholesterol is a risk factor for dementia, full stop. It's also a risk factor for heart attack. It's a risk factor for stroke. Having high cholesterol is not good for your health. Um, the treatment question is a really interesting one. And we have a lot of, as you said, what's good for the heart is often good for the brain. We have a lot of cardiac studies that indicate that statin treatment or treatment with statins in midlife seem to help protect the brain against dementia. These studies aren't perfectly designed, and there are ones in the pipeline coming out, Starry, for example, that are looking more specifically at potential benefits of statins in terms of long-term brain health. In general, and like I said before, there's no one size fits all approach for
Right.
everybody. I am never going to be a doctor that says everyone should go on the statin should be in our drinking water, but I am a doctor that is going to say that we absolutely must treat your high cholesterol, your high ApoB, your high LDL-C. And I'm especially in that boat if you have high risk genes like ApoE4, which make that a super important modifiable risk factor for you. I do think that there's a lot of fear and a lot of unnecessary fear about statin use. Statins are not bad for the brain. They're not the right drug for everybody, like I said, but in general, we have to shift away from being afraid of pharmacological agents, because at the end of the day, if you have specific genes that are putting you at risk, I don't care what you do to your diet. Like, of course I do, but that's not
Right.
going to change your baseline levels because your genes are working against you. And this is when we have to turn to science and medicine, which has helped us all this time, and take the medications that are going to do good for your heart and for your brain.
Well said. Amen to that. Let's talk about testing and assessment for Alzheimer's disease and dementia or early brain changes. What types of blood markers or imaging tools do you use for someone that you might suspect is going down this path?
Great question. So there are a lot of tools in our toolbox now, and more so now than there were 5 to 10 years ago. So great, like the field is really moving forward here. Um, in addition to doing or checking things like genetics, as we said, and our lipid panels and our metabolic panels and our hormones and various nutritional markers, things that we would check for our health collectively, there are some more specific tests that can help understand someone's baseline brain health. So, cognitive testing, that's been around for forever.
Mm-hmm.
Neuropsychologists have used this for years and years to diagnose both neurodevelopmental disorders like dyslexia and ADHD, as well as neurocognitive disorders like dementia. So, understanding someone's baseline cognitive function is wildly helpful. It's one of the first steps for me because I can't always determine based on someone's symptoms if this is a concerning cognitive profile or not. So this helps give us a clue. In addition, it helps establish someone's baseline, something that we can follow over time because cognitive function is best assessed longitudinally. So
Mm-hmm.
that's one data point. Another one that can be very helpful is brain imaging. This is not recommended routinely by most neurologists, but we'll say for healthy people, I actually love looking at a brain MRI because I can see evidence of things like vascular changes, damage to the small blood vessels in the brain, atherosclerotic disease building up in the brain, and that can help guide how aggressive we should be in our management of cardiovascular risk factors. So I think an MRI of the brain can be wildly helpful for everyone. It's not necessarily a diagnostic tool for Alzheimer's or Lewy body, although there are signs on it that can suggest that somebody may have one of these diseases. For example, we can see brain shrinkage in certain regions of the brain as it relates to Alzheimer's disease. That region we look at is the hippocampus, that's our memory center. And if we see shrinkage there, it could be a sign in the right clinical context that something else is going on. There's also lots more fancy types of sequences we can do on brain imaging to look for things like iron, which might suggest someone's at risk for Parkinson's and so forth. If someone truly has cognitive issues or cognitive impairment, we also have more advanced imaging that can look at deposition of amyloid in the brain, deposition of tau in the brain with specific scans. I don't routinely recommend them. They do expose you to radiation, but if you have symptoms, they may be worth doing. And then more recently, it's become possible to test for proteins in the blood that could indicate that someone has a neurodegenerative disease or maybe on the path to developing a neurodegenerative disease. We can test for things like amyloid proteins and tau proteins, as well as neuroinflammatory and neurodegenerative proteins in the blood. And these can become positive before symptoms start. So maybe, or when subtle symptoms start that don't necessarily flag any sort of doctor as I have a developing neurodegenerative disease. I think these are incredibly powerful tools, but they have to be used in the right context and with appropriate education. There are a lot of ways now for people to go out on their own and test for these proteins themselves through direct-to-consumer testing. And unfortunately, the quality of those tests can be very variable. The results that you get can really vary depending on how your sample was handled and processed. And I've seen a lot of incorrect test results from that. And unfortunately, once you get those results, you need someone to help you make sense of them. So doing these tests on your own I don't personally recommend it because you don't know how to make sense of it for yourself, and you're not even 100% sure that the tests are going to be accurate. So I really recommend testing with a neurologist who understands the proteins, who's able to help talk you through that decision of like, okay, if we find this, then what are you willing to do? Are you willing to do XYZ treatments? Would you want to be enrolled in a clinical trial? There's lots of discussions and decisions to be had, and that really has to take place in a doctor-patient relationship.
Yeah, that's such good advice. And, I really love you mentioning the at-home tests and the cons to doing that on your own, and talk about really spiking your stress and anxiety, and depression and sleepless nights. Like, that's one sure way of doing it on your own. Going back to the blood test where you can look at the amyloid and the tau buildup, that's really cool to me, and that's really interesting. And is that something that is considered preventative approach? Is that something that, like, I would want to go and take and say, okay, here's what's showing up, and now I know my next steps. I already have my lifestyle dialed in, but let's just say there's someone like me. I take that test, something comes back, and you say, all right, let's sit down and talk about what's going on in your options, even though your lifestyle is dialed in.
Yeah, I mean, amazing question. This is, I think, where the field will eventually go. Right now, the way that doctors are using these blood tests are mainly for binary, like your values meet a certain threshold that would suggest you likely have this pathology developing in your brain. They're not using it as, we'll say, outcome measures to monitor efficacy of various treatments. In some studies, research studies, they are being used more and more in this capacity, but we don't yet know what the normal range is for people who are asymptomatic. Most of the testing that has been done has been in people who have clinical symptoms. So all
Mm.
these established
Yep.
norms that we have are not necessarily translatable to people who are at risk. So part of our research is really to understand what the normal range is for people, and also to understand what specific biomarkers are good ones to use longitudinally so that we can actually monitor the efficacy of the treatments that we're giving. For example, going back to the very beginning when we asked, like, well, can hormone replacement therapy help a woman who's 70 years old? Well,
Hmm.
I don't know, but an amazing way to answer that question. And in the future, what we'll be able to do is say, well, let's test your biomarkers before, let's put you on hormones, and then let's test them after and see what happens. But right now, we don't know which biomarkers are the best to follow in that specific situation, and what the expected variants of these proteins are time point, if that makes sense. But it's going to
Yeah.
happen. It's coming.
Yeah, yeah. Yeah, because I think of in heart disease risk, I think of the CAC scans, I think of, the new Clearly test you can take. I think of other things that you can do that are really going to map out your treatment plan with your physician. But it doesn't sound like for someone like me, that's really very clear or available for my brain health at this time, except maybe the
Um,
ApoE4.
yeah, they are available, but I recommend doing it with the supervision of a physician.
Right, right. That's what I'm
Yeah.
saying.
Yeah.
Right. Okay. Okay. All right. So this kind of like transitions us into those 14 modifiable risk factors by the Lancet Commission. There's 14, right? It's not.
As of now, they have officially put their foot down and said there's 14. I think there
Okay.
are a lot
Okay.
more than that,
Okay.
but
Okay. So
14.
I'm going to link the list to the podcast episode notes so we don't have to go through all 14 because we don't have time for that. But I actually highlighted a few I was really interested in talking to you about. And one was, and you've mentioned it before, depression, stress, and anxiety. So depression is on the list officially. So how does that influence our risk for getting Alzheimer's disease?
Yeah, it's a fantastic question. And mental health issues such as depression and anxiety have been hotly debated in this field because they also are signs and symptoms of an underlying neurodegenerative disease. So there's
Mm,
always this question of, is it chicken versus the egg? Did the depression lead to Alzheimer's disease, or was it just an early sign that someone's brain was already at risk? I personally believe that it is a large contributor to neurodegenerative disease. And whether that's due to direct impacts of the depression on neurotransmitters and the way that the brain signals to different areas of the brain that put people with depression at higher risk, or it's indirectly related to brain health, such as people who are depressed don't have the best diet, they don't sleep well,
mm,
they
mhm.
aren't motivated to exercise, they're more likely to be socially isolated. All of those things impact our brain. So it's hard to
Yeah,
imagine how depression doesn't directly contribute to cognitive decline itself. And what I think is really fascinating, and what I've seen in some of the work that I've done, is that antidepressants can be wildly helpful. We are so afraid, I think, as a society, due to the stigma related to mental health, about seeking treatment options, especially pharmacological treatment options, because they seem like something that ties you to a diagnosis for life. But the reality is that I've seen really positive improvements in these blood biomarkers on people who are on these medications, and that translates into improved downstream effects, like we mentioned, on their sleep and their exercise and so forth. So I'm a huge proponent of us uniting brain health and mental health and trying to get rid of the stigma about ADHD, about depression, about
yeah,
anxiety, because all of that relates to our brain, and they are chemical imbalances that we can help fix and address in very targeted ways, and there's no stigma involved.
absolutely. Such important information to know. I did a podcast recently on ADHD and perimenopause with Dr. Mandelberger in New York City. And, she talked about the brain changes that are going on and that you can use these SRIs and SSNIs together with hormone replacement therapy to really help this woman move through this transition and improve her brain health, which, like you're saying, is connected to her risk of Alzheimer's and dementia.
And at least what some studies suggest is that, as we said, women's brains are different than men's brains. Women
Yep.
seem to be more susceptible to the harmful effects of things like depression and anxiety.
Yep.
So it's extra important to seek care when it's appropriate.
Yep. The other one I find really interesting is diabetes on the list, and I wanted to speak with you about um, the insulin resistance, pre-diabetes, diabetes, and then the effects that GLP-1s are having on our brain health and the connection there. Because so many women that I speak with and work with have insulin resistance, but their physicians are not willing to acknowledge that they're at like, a 99 on their glucose or something. They're right there on the edge. And, they just want to wait till it gets out of range and then it's in a range so that they feel like they can do something instead of having this prevention approach to their health. So, can you tie all of these together in terms of how diabetes is connected to Alzheimer's and dementia risk?
Yeah. And it's so important that you said, like, just because a physician told you that your labs looked good or normal, it doesn't mean that they're not optimal.
Right.
And when it comes to, unfortunately, when it comes to cholesterol, when it comes to blood pressure, and when it comes to insulin resistance, we often see that these things have been left like fine, but not good, not optimal for many, many years.
And thyroid labs.
Yes, yes, have just been left like, well, they're fine. Like you don't need treatment. And who's to blame for that? I don't know. All I can say is that we're educating you now to
Yeah.
understand that just because your labs may have been good doesn't mean that they're optimal and that you don't have early signs of insulin resistance. So, how does insulin resistance contribute to neurodegenerative disease? That is a loaded question because there are likely so many mechanisms by which it does contribute to neurodegenerative disease. One is that we know it contributes to atherosclerotic disease. It changes blood flow or vascular delivery of blood to the brain, which, of course, depriving the brain of blood flow and oxygen is not great. But insulin and insulin signaling also have direct roles in the CNS. So we understand that insulin is an important signaling molecule for the brain. And there's this idea that not only peripheral insulin resistance, but central insulin resistance, meaning your brain's ability to respond to insulin signals, becomes disrupted in Alzheimer's disease. And the brain's ability to utilize glucose or sugar appropriately becomes impacted in Alzheimer's disease. And that all does start peripherally.
Mm.
We understand that insulin resistance often comes with body composition changes, and those things also contribute to neurodegenerative disease. We often see high levels of visceral adipose tissue or fat
Mm.
around the organs in the belly, which is that really pro-inflammatory, metabolically active fat tissue that contributes to brain aging by secreting a lot of these inflammatory molecules and cytokines that contribute to neurodegenerative disease. And then, of course, muscle mass, which um, is not as spoken about as I think visceral adipose tissue. I think a lot of people understand and see like, well, having high elevated body fat and visceral adipose tissue is not great for my health, but a lot of people don't know that they're walking around in maybe 125 pounds, but 38% of that is body
Right.
fat.
Right.
So, like, that is not an uncommon thing. We've seen that like
Yep.
this week, like twice this week,
Yep.
when women come in and they're like, well, yeah, I weigh 120 pounds. And I'm like, 120 pounds of no muscle at all.
Right.
And our muscles are our glucose disposal systems. Our muscles directly take up glucose from the periphery and utilize it, and they don't need insulin to do it. So they're pretty magical in that way. We got a little bit off tangent on your ultimate question, but yeah, so many ways by which
Yeah.
insulin resistance contributes to poor brain health.
Yeah. And so, how do the GLP-1 medications help with lowering our risk for Alzheimer's disease and dementia? If we're talking about insulin resistance, if we're talking about this metabolic dysfunction, that the door to that is opening in the menopause transition, right? Estrogen helps with insulin sensitivity, and we're losing that. And women are becoming, they come to me and they say, I never had this fat around my belly before. I'm wearing this tire that never existed. And everything I used to do beforehand no longer works for me.
Yeah.
But the
So,
GLP-1s come in and they help support this overarching goal of health and wellness.
yeah. So again, no one size fits all. So they're
Right.
not the right drug for everybody. And
Right.
specifically, if you are one of these people who's walking around at 125 pounds
Right.
and almost 40% body fat, you're not the right person for it because you don't have the muscle mass buildup or reserve to really be safe on one of these medications.
Right.
But um, so aside from the obvious of course, if we treat peripheral insulin resistance, that's going to benefit our long-term brain health. And GLP-1s are great medications for treating that. But they probably also have downstream effects that aren't fully accounted for by their effects on insulin resistance. So, for example, they decreased inflammation. Inflammation is like this buzzword that people are like, what
Right.
does that mean? Like decrease inflammation. But they do, they decrease neuroinflammation specifically. And they change the way that the brain the way that the brain transmits neurotransmitters or produces neurotransmitters. Like we don't think about how once someone goes on one of these drugs, like their cravings decrease. That's because they're changing the way the brain is making hormones and transmitters.
Mm-hmm.
And that effect likely also contributes to how they may help long-term cognitive function because of the way they're changing the way the brain is producing these chemicals that can be so impactful. And then finally, finally, they help with decreasing accumulation of certain toxic proteins, such as tau specifically. We've seen this in our research. It's been reported pretty heavily in the literature that people who are on these drugs have a lower phosphorylation, or what
Mm-hmm.
makes tau turn into tangles um,
Mm-hmm.
in their brains. So lots of downstream effects of these drugs. I think they have tremendous amount of potential when used appropriately, dosed appropriately for the right person.
Yeah. So you were mentioning that woman who is 120 pounds with maybe 38 to 40% body fat. That's where the exercise, which of course you're a huge proponent of, getting in that weight training and really building that lean muscle mass and being sedentary is one of those 14 modifiable risk factors. So exercise is huge. I wanted to end our podcast on supplements for brain health because this is a huge question that is in all over the metaverse. And I get this question a lot. And I don't love pushing supplements on people. I want to keep it really simple and really make an impact on them. So, what supplements could be helpful for brain health in that prevention approach to Alzheimer's risk?
Yeah, this is such, unfortunately, a dirty market.
Yes.
There are countless supplements marketed to improving cognitive health and brain health. I feel like there's a new one on the market all the time. And unfortunately, a lot of them have proprietary blends of who
Yes.
knows what.
Big red flag.
Big red flag. So, I like to say I'm an equal opportunist. I like medications. I also like supplements for the right person. There isn't a perfect brain health supplement out there. There isn't one that if you start taking, it's going to help your cognition instantly. Like it's just not it's just not reality. Unfortunately, it's really, really good marketing for like the select person. But there are certain supplements that I do use depending on what I see in someone's labs. So, for example, we know that B vitamins are the utmost important for brain health. If your B vitamins aren't optimized, whether that's due to some sort of genetic factor you have, or you aren't really metabolizing B vitamins appropriately from your food sources, or you just, based on what you're eating, you're just not getting enough B vitamins, well, we need to correct that. But in order for those B vitamins to work, you also have to have really optimal levels of omega-3 fatty acids. It's difficult for a lot of women. It's difficult for especially ApoE4 carriers to get enough fatty fish and to get enough DHA, which is this
Mhm.
protective fatty acid for the brain from food sources. It's more difficult for them to absorb and transport that through the blood-brain barrier. So for a lot of women, omega-3 supplementation can be wildly helpful. It's of course not without risk. So always talk to your doctor first. It could cause abnormal heart rhythms and bruising and so forth. So not for everyone, but for a lot of women, it can be wildly helpful. And then I always look at vitamin D. The studies on vitamin
Mm,
D are so mixed, and there's lots of reasons for potentially why vitamin D is not necessarily the thing to look for brain health. But a lot of studies show that people with lower levels of vitamin D have a higher risk for Alzheimer's disease and other neurodegenerative diseases as well. And we do know how important vitamin D is for bone health. And I would be remiss to say that I do care a lot about bones, because fall prevention is
yeah.
neurodegenerative disease prevention. If you fall and break your bones, you are putting your brain at risk, like full stop. So I care a lot about looking at my patients' bones and looking at their vitamin D levels. Very, very important.
Yeah, absolutely. Well, also, isn't one of the modifiable risk factors, wait, I have the list right here, traumatic brain injury. If you fall and you hit your brain and you get concussed, I have four boys and a girl. My boys, all three of them played hockey, one football. So even though they were wearing helmets, they still got concussed. And that is a risk factor.
Yeah, and people think, well, I've already had these concussions. Like, what can I do? Well, you can have
Right,
no more of them. Like,
right,
you have met
right,
your limit, so you have to do everything that
right,
you can. And the
right.
things that contribute to falls later in life: weak bones, no muscle mass, because you can't get off the floor, you can't
Right.
maneuver your environment very well, hearing and vision loss, other things that are
Yep.
modifiable risk factors for dementia.
Yep. I have a couple questions just circling back to supplements, especially for omega-3 for the DHA. Do you recommend 2 milligrams? Because I think this is really important for people to understand that even though you're buying a brand, and even if it's a high quality brand of omega-3, that you have to really pay attention to the amount of DHA that's in the serving, because it might not be the therapeutic dose that you need, especially as an ApoE4 carrier.
Yeah, so we don't have a perfect answer to this. And I get asked this question a ton, like,
I
how
bet.
much DHA do I need because I'm an ApoE4 carrier? Well, I wish I had a perfect answer, but what I can tell you, based on studies mainly from Yassine Hussein, who's in UCS, or he's in San Diego, I believe, the University of San Diego. A lot of his work is done on ApoE4 carriers, and what the optimal dose of DHA is needed to penetrate through the blood-brain barrier. And his work says 2 grams of DHA, which is a tremendous amount of DHA. I find that may be necessary for some people and may not be necessary for others. The best way to really check that yourself is by doing an omega
Yeah.
quant. Testing your own levels of omegas in your blood is the best way to dose. You really want to aim for an omega quant over 10% or 10% or so, if you're an ApoE4 carrier. So it depends on how much fatty fish you're eating. And honestly, everyone absorbs different amounts of omegas that they're consuming. So it's hard to predict how much you're going to need. That's the best way to know.
Yeah, I agree. And by the way, a lot of preventive cardiologists and even physicians who are well versed in lipids do add on that omega index test. So they are in the know and they are looking at that. What about creatine? There has been so much work on, and it's a very well studied supplement. It's also a really affordable supplement. And making it accessible to so many people. And a lot of midlife women are using it, obviously, for lean muscle mass and which will help protect their bones as well. But what about creatine and the brain is so special?
Yeah, so it's a great question. And I also get asked this a lot. There was a recent study, I think, where they used, I think, crazy amounts of creatine, like 20 grams
Yeah.
of creatine a day in people with MCI, Alzheimer's disease, and found some slight improvement in cognitive function in these individuals. So it has been getting tremendous attention, especially
Yeah.
on social media. I've used creatine for many, many years, not personally. I actually can't tolerate it. That's the one thing with creatine. Some women just can't tolerate it. It causes a lot of GI upset and distress. So if you're one of those women, don't feel bad.
Yeah, that's
Um,
me.
like, if you can't tolerate it, you can't tolerate it. You don't want to take it. It can be helpful for sustaining muscle mass. It maybe has some mild cognitive benefits. Um, that probably is most pronounced in people who don't eat meat, believe it or not. So
Mm,
vegetarians may see
mm.
that most. Um, and if the cognitive benefits from, if anything, they're very, very mild, just like that study showed that they were using tremendous amounts. Um, I'm not opposed to using it, but it's not something that I'll routinely recommend. If someone wants to try it, I'm game to try it, but I don't think that that's necessarily where all of the bang for the buck is.
Huh, interesting. See, it's so good to have doctors like you on this podcast because there is so much misinformation out there. And there is research that creatine can help with some
For
cognition, right?
sure.
So there is, but the way it's marketed to us is you have to take creatine and it is going to
Yeah.
change your brain. Like you're going to wake up and you are going to be
Yeah.
so hyper focused. And so the expectation out there can be really disheartening for a lot of women who might not feel. Some women might and some women might not.
Exactly.
Yeah.
Yeah, I think that's exactly well said. It They
Yeah.
just got so much hype and it made you feel like if I'm not on this, why am I not on it?
Right. Right.
And not saying it's bad, not saying it's going to harm you, but it might not be worth all the hype.
And then also make women feel badly, like if they're like me who can't. I tried to take it for 8 months. I couldn't button my pants and I wasn't,
Yeah.
for 8 months feeling bloated like that. It wasn't worth it to me. And some women might feel badly. Oh, what's wrong with me that I can't take this because I'm bloating and now I'm not going to get the brain health benefits. So thank you for breaking that down. Well, we are at the end of our episode. I honestly have to have you come back for another like 6 hours because there's just so much amazing information that you're sharing with us. But what gives you the most hope about where Alzheimer's prevention is heading, especially for midlife women or women in
Um,
general?
Yeah, well, I'll tell you a story that just happened recently.
Oh, great.
Um, because this like got me so excited and I've been thinking about it all week. We've been taught this dogma that the brain cannot regenerate new brain cells. We've been taught that like forever and ever, and we've believed this. Over the last several years, more and more studies have come out and have shown not just that the brain has tremendous neuroplasticity or ability to rewire and rework around damage, but that it also, even the adult brain, has the ability to undergo neurogenesis or generation of new brain tissue, something that we thought was never possible before.
Mm,
And one particular region of the brain where this has been shown to occur frequently is the hippocampus or our memory center or where Alzheimer's disease impacts. And I just had a patient undergo, I'd been seeing this patient for about 3 years, and her brain volumes were around, and I hate using these terms, but around the 25th percentile for her age, compared to other normative data, whatever that means. It's not a perfect ideal measure. But my best way to look at these things is longitudinally over time in a person. And her brain volume, her hippocampal volumes grew, and now they're
wow.
normalized. And I'm just like blown away because I saw it in real life on someone that I was caring for. And it was just an incredible way to see this neurogenesis that we believed never was possible happen. A complete lifestyle change in terms of cutting out alcohol completely, treating cholesterol, exercising, which promotes BDNF, which grows brain cells in the hippocampus. Like all those things actually do matter. And it's amazing to see when the imaging shows such a beautiful picture. So I'm really, really hopeful that we'll have the tools to show women the benefits of what they've been putting in time and show them like, look, all that hard work is actually paid off. Look, your brain has been growing. And that's just so beautiful and so, so cool to see.
That is an amazing story. And thank you so much for sharing that. And how long was that journey before you saw on the imaging these changes?
It's about 3 years.
And I love that you're sharing it's 3 years because women are doing the hard work. I mean, as a health coach, I try to bridge that gap between leaving your doctor's office with, either a new medication you have to go on, and maybe your doctor said, oh, by the way, change your diet, get more sleep, and do all these lifestyle interventions, and aren't really sure how to get there to their reality of life, right? How do they fit these lifestyle habits in? And that equation is unique to everyone, like our own fingerprint, and it takes time. While a health coach might work with someone on the average of 3 to 6 months, you might not start seeing those real changes for 1 to 2, and as you're saying, 3 years.
Yeah, this is the long game here.
Yes,
These
yes,
diseases form over decades, and there's no quick fix. This is a complete lifestyle change that's
yeah,
going to take years because the diseases take years to accumulate. So
yeah.
change is really slow, and it can be really discouraging when we don't see immediate results and everyone wants a quick fix with a supplement, hence why creatine
Right.
got all this publicity, but the reality is that there's no quick fix. It takes time.
Yeah, yeah. Well, thank you so much again for sharing your expertise and wisdom here, in such a field that's really confusing to midlife women and beyond. And I think that you've really helped us walk away with golden nuggets, things where maybe I always say start working with the low hanging fruit, right? Where is it the easiest place for you to start on your journey? And brain health is part of this journey of longevity. So I really appreciate how you share your information, explain things, and without putting fear into that formula.
Thank you so much. Those were such kind words. And thank you, Jill. I'm happy to come back and do
Oh,
round two whenever you want.
wonderful. Thank you so much. All right. And everyone, thank you for tuning in.
Thank you.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.